warm welcome and an Austrian service to our coverage from ESMO. The Congress of the European Society of Medical Oncology is one of the most important events in cancer medicine and took place in Berlin in October. My name is Claudia Altmann-Pospischek. I am from Austria and have been living for 12 and a half years with metastatic breast cancer. I'm a patient advocate and blog under Claudia's Cancer Challenge. On behalf of patients today and the breast cancer magazine Mamma Mia, I am very pleased today to have the opportunity to speak with one of the leading German women in oncology, Professor Dr. Nadia Harbeck, and to take a look at significant new studies that were presented at ESMO. Professor, would you like to briefly introduce yourself?
Yes, gladly. First of all, thank you very much that we can do this together. My name is Nadia Harbeck and I head the breast center at the LMU clinic in Munich.
Thank you very much. We have taken a closer look at a few studies on metastatic breast cancer that are of particular relevance from a patient perspective, and we will now focus on the subtype hormone receptor positive. And with that, I am happy to hand over to our medical expert, Professor Dr. Nadia Harbeck.
Yes, thank you very much. We have selected 3 studies that won't immediately change therapy tomorrow, but may show us effective concepts and also demonstrate how safe the therapies are, especially in the last study for older patients as well. Let's start with a presentation on the SERENA-6 study by Ms. Meyer from the USA. SERENA-6 was a study involving patients who, in first-line therapy, had HER2 negative hormone receptor positive disease and were treated with an aromatase inhibitor and a CDK4/6 inhibitor. Blood tests were then performed every 3 months or so to check for the occurrence of an ESR1 mutation. That means whether the tumor cells in the body change and develop resistance to this therapy. And then the patients in whom this was the case were randomized to a new therapy. Instead of the aromatase inhibitor, camizestrant, which is an oral SERD, this is a therapy that essentially works by folding up the estrogen receptor, thereby inactivating it and preventing it from functioning. And we know, or many patients know, about fulvestrant, and camizestrant is a newer option in this class. Further development, which can also be administered as a tablet. The patients either received camizestrant or were randomized to remain on their original therapy. Maybe to clarify it again for better understanding, more than 3,000 patients were screened, then 3,256 were allowed to participate in the study and receive this ESR1 monitoring, which means searching for a mutation in the estrogen receptor using tumor cell DNA in the blood. Then in 548 women, this ESR1 mutation was found, of which 51% were already detected at the first test, and of those, just over half were randomized, 315 women for the study. That means, just to illustrate, you have to examine a lot of patients and regularly collect this liquid biopsy in order to find patients in whom there is what is called molecular progression of the disease. That means you can see it in the tumor cell DNA, but it is not yet visible on the X-ray. The study itself showed a benefit. The time to progression was significantly extended with the early switch to camizestrant to this oral SERD, and now Dr. Vazloy from Paris presented the quality of life data. And here too, you can see that the quality of life of patients on camizestrant, that is with an early switch at the onset of molecular progression as detected by tumor cell DNA, was significantly better, with less pain, better physical functioning, and better role functioning than under standard therapy. And here you can see it visually again, the diamonds. But if they are positioned to the left of one, then it was considered an advantage for camizestrant. So you can say that this early switch in treatment was actually better for the patients. They were also less burdened by the early switch. That's quite interesting because, of course, you might also suspect when you do regular blood tests during a therapy that is actually working well, like a CDK4/6 inhibitor with an aromatase inhibitor. Of course, that also puts a burden on patients, but that could not be confirmed in these analyses. Patients had a better quality of life, less pain when they were switched early. So you can say that this SERENA-6 concept, the early switch of therapy to an oral SARD, while continuing treatment with a CDK4/6 inhibitor was beneficial for the immediate further course of the disease and for quality of life. In my opinion, we still need somewhat longer follow-up data to also see whether patients might actually live longer if we switch therapy early, because of course that would be, so to speak, the ultimate proof that this is a new therapeutic concept. If you only delay the course of the disease somewhat, but in the end it doesn't really matter, then of course you have to discuss these ongoing blood tests with the patient more critically than if you really know that you can actually improve survival time this way. And ultimately it is, the camizestrant has not yet been approved either. We assume that approval will be granted in the near future. And that's why at the moment, in everyday clinical practice, we are not yet at the point where we regularly check for resistance in the blood before a therapy, so to speak, shows signs that it is no longer working well, as seen through changes in CT scans. And I think that's also something we should perhaps discuss again for everyday practice. When do we switch therapies? At the moment, the guidelines certainly state that we do this when progressive disease is detected in CTs, PET CTs, or X-rays.
Thank you very much, Professor Harbeck. Here, pain is generally being discussed. What kind of pain are we talking about here?
Well, it can be assumed that patients, especially in this disease situation, experience bone pain because that is by far the most common site of metastasis. And you can imagine that patients simply do better with this earlier therapy switch, which was also discussed at ESMO, whether perhaps the bone pain is also caused by the aromatase inhibitors. Although I think the body does get somewhat used to them, but of course it could also be that camizestrant simply in terms of is better tolerated when it comes to bone pain.
And what are the common side effects of camizestrant typically?
Yes, it's an oral SERD. We already have one in therapy, elacestrant, which we are allowed to use. For ESR1 mutations, it's a second or third line therapy, and these are generally very well tolerated. Sometimes there are also gastrointestinal complaints, a bit of discomfort, and as for camizestrant, we haven't worked with it yet. If you look at the study data, sometimes it also causes visual disturbances, like seeing flashes of color at the side. This happens 2 or 3 times a day. It does not involve any organic changes in the eye and is, according to the investigators who participated in the study, which is also reversible. So it doesn't seem to have any lasting impact on quality of life. So overall, these new substances are well tolerated.
Very good. You just mentioned elacestrant, which is effective in ESR1 mutations. If that fails, could you then try camizestrant afterwards?
I don't really think so. I think this is a therapy class oral SRD. Imlunestrant is already approved in the USA. We're now waiting for approval in Europe. Camizestrant isn't approved anywhere yet, but I still thought that this is abstractly interesting because this kind of monitoring during ongoing CDK4/6 inhibitor therapy is something that might become relevant if the SERENA-6 study shows that it also improves the course of the disease in the long term and not just in the short term.
Very good. Thank you very much. Then let's move straight to the next study.
Yes, the next study was a study from the Netherlands, the SONIA study, where we've now seen an update. The SONIA study is also a study for patients receiving first and second line therapy for receptor positive, HER2 negative disease. And what the study did was compare whether you absolutely have to use the CDK4/6 inhibitor in the first line or whether you can also use it in the second line. And in this case, the first and second lines of therapy were predefined CDK4/6 inhibitor plus aromatase inhibitor. In most cases, the patients in this study received palbociclib because that was simply the first approved substance, and then fulvestrant in the second line therapy. And the second group, that was an allocation by chance, a randomization. They then received an aromatase inhibitor in the first line therapy, and then CDK4/6 and fulvestrant. And we already know that the time to progression was somewhat better. Of course, when the CDK4/6 inhibitor was added, and now the question was whether this plays a role in the patient's survival. And it was observed that overall the patients survived just as long, regardless of whether they received the CDK4/6 inhibitor first or later. But it has been shown that for younger women, it can indeed be advantageous if you start at an early stage with the CDK4/6 inhibitor. And yes, well, then here you can see the illustration from the conference again, where you can see that for the overall patient population, it didn't make a difference whether they received it as first or second line therapy. But for the younger women in what is called a exploratory analysis, it was seen that it was indeed beneficial to get it as early as possible. It must be said critically, this study has actually already become outdated because we now give CDK4/6 inhibitors, especially ribociclib and abemaciclib already in early stage breast cancer. In this study, all the patients had not yet been pretreated. And at least in Germany, we also give, I think that in Austria as well, fulvestrant is not necessarily used as a second line therapy, but rather we try to combine it with targeted agents against the AKT signaling pathway, keyword PIK3CA mutation, or also in the case of ESR1 mutated tumors, to work with elacestrant, a so-called oral SR, so that perhaps the second line therapy was somewhat undertreated compared to how we would do it, which is why I think the SONIA study is relevant for individual patients who perhaps in first line therapy do not necessarily want this combination with a CDK4/6 inhibitor, are already postmenopausal and say, no, I want to see the doctor as little as possible. I'd rather go only more frequently when the disease progresses further. But for young women, for example, it is not suitable. And above all, the study is also important for countries where not every patient can afford a CDK4/6 inhibitor. So you can say it's not so bad, even in the second line of therapy, if you can then afford it, or if it is then covered by the state or by insurance, it can still be very helpful for everyday therapy in Germany or also in Austria. I think this study is no longer relevant because both the previous therapy and the second line therapy have already changed here. Both the initial therapy and the second line therapy have changed significantly.
Thank you very much, Professor. One question: why is early intervention advantageous for women before menopause? What is the reasoning behind that?
That wasn't really discussed in detail at ESMO. I assume that these young women partly have more aggressive disease courses, and that, of course, combination therapy is significantly more effective in these cases. We also know there was a study with the CDK4/6 inhibitor, specifically for young women, the MONALEESA 7 study with ribociclib, and it showed the longest survival times to date in this group of young women with metastatic receptor positive disease, namely almost 5 years median survival. We didn't know that before at all, so we can assume that for young women, this combination is simply more effective because the course of the disease is a bit more aggressive. Whereas women after menopause, sometimes perhaps even with just 1 or 2 bone metastases, can do very well for a long time with anti-hormone therapy alone.
Thank you very much. And now let's move on to therapies for older women.
Exactly, that was a poster, but I thought it was also important because many of our patients are older, and it's good to give them some encouragement that these new targeted therapies also have their place here. This is about palbociclib. As I already mentioned, there are 3 CDK4/6 inhibitors: ribociclib, abemaciclib, and palbociclib. Palbociclib is a substance that has been approved the longest. This also explains why many of these studies are conducted with palbociclib. The PalomAGE study is a real-world data set from France, meaning that patients were simply included for whom the therapy indication for palbociclib was established, women aged 70 and above. These are patients who are often not included in the randomized approval studies because they sometimes have comorbidities. That is, they have additional accompanying illnesses, and so the studies tend to include younger, generally fitter patients. The fact that our French colleagues managed to do this, hats off. That really deserves praise. The average age was 78 years, and almost half were over 80. I find that quite remarkable. The patients were in the first or second line of therapy. Many were already a bit further along in their disease, and 50% of the patients had organ metastases, and almost 70% had a so-called G8 score below 14. That actually indicates that the patients have comorbidities and are not so fit anymore. In German, you would probably say they are frail. And that's why these are patients where many therapists might say, is it really necessary to use such a CDK4/6 inhibitor? And they had all received palbociclib, and then the treatment goal was to see how many would have to permanently discontinue their therapy within the first 6 months. And then they also looked at what side effects occurred, how was the quality of life, and they also looked a bit at how this compared to the geriatric assessment, meaning this more detailed examination with a focus on what patients are still able to do in their daily lives, for example. And then they also looked at how long it took until the therapy stopped working. What they found was that 32% of patients discontinued, so about a third. That is certainly more than in a younger group. About 40% had a dose reduction. It should be said, perhaps with more dose reductions or earlier dose reductions, it might be possible for some of the older patients to be able to receive these substances for a longer period. And it was observed that frailty, meaning a low G8 score, was also a risk factor for discontinuing therapy, has shown. As for the side effects, it must be said that in older patients, they are not different from those in younger patients, but perhaps a bit more frequent. And palbociclib mainly causes these blood count associated toxicities, but 8% here discontinued treatment permanently. So it can be managed, but I am a big proponent of dose reduction, early dose reduction, in order to prevent problems from arising in the first place. And I think these are figures we can work with in everyday practice. We can also discuss this with our patients and say, look, the probability that this will work is about 2/3, but we should talk early about side effects. What we know is that if we have to discontinue therapy with these CDK4/6 inhibitors due to side effects, or if we have to reduce the dose, we still maintain efficacy. That means a dose reduction due to side effects does not result in a loss of effectiveness. And I think that's something you have to tell patients early on so that they feel comfortable discussing the side effects. Here you can see again the patients with and without discontinuation, and you can see the lighter ones are those who discontinued, and you can see that the physical complaints were simply greater in those patients than in those who did not discontinue. And perhaps it should also be said that not every patient over 70 with many comorbidities is able to undergo these combination therapies. But you can also put it positively. After all, 2/3 managed to do it. Maybe now that we know more about the relevance of dose reduction, perhaps we can accommodate some patients as well. We have patients for whom we even go a bit below the dose prescribed in the official product information, and they actually do very, very well with that in clinical practice. So I believe the Paloma study is very important for our education for patients, to also encourage them that even at an older age, and I mean 70 isn't really old these days, but even with comorbidities, such a combination therapy can be carried out successfully as well. But we also have to be self-critical and say that if patients are frail, then they also have a higher likelihood of discontinuing treatment earlier. And then you have to ask yourself in each individual case whether this combination therapy with additional examinations is really necessary. Perhaps with more frequent doctor visits, you always have to weigh up quality of life as well. And if patients actually prefer to stay at home and don't really want to go to the doctor much, are limited in what they can do, then you also have to say that maybe a purely anti-hormonal therapy is also a good treatment. And as we just learned earlier in the SONIA study, you can also change your mind if the disease progresses further or if symptoms develop, and then add a CDK4/6 inhibitor without the patient losing overall survival time. And I think that's my conclusion from the Paloma study. CDK4/6 inhibitor, palbociclib, is quite feasible in older patients, but you also have to critically discuss with the patient and their relatives whether, let's say, the increased number of doctor's visits and follow-up examinations is really something the patient is willing to accept and says, yes, I'm willing to go through with that, in order to perhaps overall delay the time until the disease progresses, to be able to push that back.
Thank you. Professor, one question, why do we always start with the maximum dosage? For palbociclib, that's 125 milligrams. I know that. Then it was reduced to 100 and then to 75. And with 75, it just barely worked. And especially for older patients who are also frail, this dosage of 125 is already very, very, very high. And I also know hardly anyone in my community who was able to stay at 125 long term. Why can't you start at a lower dose?
We know that the effectiveness is maintained even if you reduce the dose due to side effects, because side effects are probably a sign that the body can also manage well with less medication and can cope with it. For abemaciclib, for example, there is a study where the dose was titrated up from a lower starting point, and it was observed that more patients could actually be treated well or for longer with the full dose. Personally, what we actually do is start with the full dose, but then very quickly within the first 1 or 2 cycles, try to find the dose with which patients can manage their daily lives well. Because just based on age, or if when I look at my patients, I have very slender older female patients where I think this won't go well with 125 milligrams. And then after half a year, they're still on 125 milligrams. And I have younger women where I think, well, the full dose will surely work, who then after half a year end up on 75 milligrams. So you really can, as a therapist, you can be mistaken too. And I always worry that if you start from the bottom, you might forget to go up another dose level and that you might end up with a suboptimal dose and therefore perhaps achieve less effectiveness. And I want the maximum effectiveness for my patient. So I'd rather reduce more quickly than start too low and then out of convenience, just stay at the lower dose.
That's a very good thought. And what we need, of course, is effectiveness and good quality of life. Thank you very, very much. Even though metastasis is, of course, a heavy burden, these new findings sound like a better and more manageable path, like more lifetime and better quality of life. And of course, we are happy about research and development because we benefit from it. Patients benefit enormously. Thank you very much for your clear and comprehensible explanations, dear Professor Dr. Harbeck. Your remarks are encouraging and give hope, and that's exactly what we need. And with that, we have reached the end of this hormone receptor positive blog from the ESMO coverage, and I thank you very much for joining us.